Welcome to episode 5 of Community Health Worker Data Dialogues, the podcast where we dive into how data is transforming community health worker programs around the world. I'm Dr. James O'Donovan, Director of Research at Community Health Impact Coalition, and I'm joined by my co-host Dickson and Seaman Bewe, a community health worker from Malawi. In this episode, we're going to be speaking with Dr. Matthew Harris and Dr. Nina Zhu from Imperial College and the Fleming Initiative, and we'll be bringing together all of the topics that have been discussed in the previous 4 episodes to view the challenge of data through the lens of antimicrobial resistance and the role that community health workers play within this. But before we hear from Matt and Nina, let's hear from 2 community health workers in Brazil about the challenges they face in relation to AMR.
But people tend to misuse antibiotics. For example, if the doctor prescribes 12 days of antibiotics, the patient might stop after 3 days, once they feel better. Then, they store the leftover antibiotics for later use. This happens a lot. It's very hard to control, but we are always keeping an eye on it. For example, I have a 9-year-old patient suspected of having tuberculosis. He goes to the clinic every week, but I visit his home every day to make sure he actually swallows the medication, because treatment adherence is difficult. The pills are horrible and big, and people need a lot of motivation to stick with it. There's also a major issue with people sharing antibiotics. For example, someone takes 3 days of antibiotics, feels better, and then gives the leftovers to a relative with similar symptoms. Some people really don't have the money for the full treatment, and others think they know better and start acting like doctors, giving away their own medication. We see this all the time.
Hi, Nina, Matt. Welcome to the studio. It's great to have you here. Nina, I'd love to ask you to introduce yourself, tell us a little bit about your work and your work with the Fleming Initiative.
Sure, and thank you for having me here. So my name is Nina Zhu. I'm part of the Fleming Initiative. I'm also a research fellow at the Centers for Antimicrobial Optimization Network, CHWs for short. I also lead one of the research team in the NIHR Health Protection and Research Unit in antimicrobial resistance and healthcare-associated infection. I know it's a mouthful, but I will tell a little bit more about that later. So my work is focusing on addressing antimicrobial resistance using data, basically, a lot of quantitative stuff. I've been working around numbers for over a decade. So that's me, very short.
Incredible. It's an amazing background. And Matt, same to you, if you could just introduce yourself.
Thanks very much, James. Pleasure to be here. My name is Matthew Harris. I'm a clinical reader in public health medicine at Imperial College London. I'm the theme lead for innovation and evaluation within the North West London Applied Research Collaboration, which is an NIHR-funded programme grant to do applied research within North West London and beyond. And I'm also director of postgraduate taught programmes in the School of Public Health within Imperial College London. But I have a background having worked as a general practitioner in the Brazilian family health strategy good 20 years ago now, and have therefore several years' experience working with community health workers and have led efforts to translate the community health worker model from Brazil into the UK NHS, where we now have it across multiple different localities happily. So it's great to be here.
Yeah, it's fantastic. Amazing background, Matt, and really excited to actually ask you a lot about antimicrobial resistance and the role community health workers can play in that within this episode. But Nina, I thought just first of all, for the listeners' benefit, can you explain what antimicrobial resistance is and why it's such a major global challenge?
Sure. So first of all, we have to know what microorganisms are before we touching AMR. So microorganisms are small creatures, basically. From the size smallest to the largest, they can be virus, bacteria, fungi, and also parasites. I think COVID, the pandemic, also bring a high level of awareness around microorganisms. So essentially, antimicrobial drugs are the medicines we created to treat infection caused by microorganisms. But sometimes, because of the mutation, it's first of all, I have to say AMR is a naturally occurring process. It's not completely created by anyone. It's happening in nature. that the microorganism become resistant as they develop the ability to survive when the drugs present. However, I have to say there are human factors that drive and accelerate the process of antimicrobial resistance, which I will touch upon later. So essentially, since antimicrobials being invented, like penicillin by Sir Alexander Fleming, this is always a concern because essentially mutation of microorganisms, because structure, they have a very simple structure. So the process happens within seconds. So basically, no matter how hard scientist community work, there is no way we can catch up the speed of these little bugs mutate. So essentially, all I'm saying is we are running out of options to treat infections. So if we do nothing, and then the modern medicine would collapse, because all the simple procedures we can think of getting a very small cut or wound from playing outside, or to all the operations like cesarean section, all this involved in preventing and treating infections. So if we do nothing about AMR, we are running out of options very, very soon. So that's why it's a global public health concern. It drives huge patient suffering, morbidity, mortality, and also economic cost globally. And that's why we call it the threat of modern medicine and a silent pandemic.
Okay, thanks. That's an amazing background as to AMR, and also the global challenge and problem that it presents currently, but also in the future. And I'm really excited in this episode to just try and understand how community health workers can play a role in combating this. But thank you for that amazing overview. Dickson, I'll hand it over to you. I know you've got some questions for Matt.
Yeah, thank you so much, Nina and Matthew. Yeah, I'll start with this question. What are some of the examples of the general interventions being employed globally that support AMR mitigation? Okay, let me start with Nina.
Fantastic. Okay, so there are a lot of different types of intervention. For example, antimicrobial stewardship essentially is the intervention aiming at improving prescribing or use of antibiotics, because misuse of antimicrobials is I'm confident to say is kind of the number one driver for AMR globally. But that comes with two sides, both underusing and overusing. So stewardship interventions aiming at promote appropriate use of antimicrobials. But that must be associated with other type of intervention, for example, implementing of rapid diagnostics to ascertain what is the pathogen that's causing the infection. There are also training programs to raise awareness, and also promoting the good use of guidelines, promoting the good use of hygiene as well, because it's a very fundamental thing. If you prevent the infection in the first place, and then you later don't need to use antimicrobials, and hence you stop the AMR after all. So infection prevention interventions that involving good diagnostics, good use of hand hygiene and personal protective equipment, for example, and also raising awareness, appropriate use of guidelines, etc. All these kind of interventions. But more recently, we also have more data-driven approach, for example, using artificial intelligence, which I'm pretty sure we'll touch upon later.
Yeah, no, it'd be great to touch upon the point about artificial intelligence. Just to ask you a little bit more, so this whole podcast series is about the role of data in community health worker programs. Why does data play such an important role, specifically in relation to AMR more broadly? And then, Matt, I might come on to you just to ask about the role CHWs are playing in this, or the role they could play. So Nina, I'll just ask why data is so important, first of all.
Sure. So essentially, surveillance is a key factor in addressing infection and AMR, both, because without that, we don't even know, for example, in each of the locality globally, like what is the burden of AMR. So initially, that involves in understanding what proportion of the pathogen you identify that is resistant to different type of antimicrobial medicine. But later on, different types of data must be incorporated, because infection is a little bit different. Because, okay, a very typical example I want to give is urinary tract infection. It's very common. It's the number one common infection among females globally. But it doesn't, but once you see a bug, a bacteria in the urine, doesn't necessarily mean an infection is present, because infection also involves other type of clinical symptoms. For example, having a fever, raised temperature, etc. So having the data around bugs alone is not that meaningful. It's critical, but it's not that meaningful. So you've also seen data from other aspects as well. For example, the data about the patients themselves, the data about infection. So that's why, but also critically, the data around antibiotic prescribing. So globally, we have, I would say, relatively mature surveillance around the bugs, but we're missing other parts of the whole story. So at the moment, the challenge we're facing is to get the data from other aspects and linking them together. So that's a kind of like a very quick overview of what's going on at the moment.
I think that's a really interesting point, and something that the Fleming Initiative do really well.
Precisely.
Is to bring together so many different actors in this space. And we just touched upon this actually in episode 4 when we were discussing about data quality and community health worker programs. It's not just about the community health worker who's collecting the data, it's about who's using the data, say at the district health office level, at the government level, and how all of that holds together. So I think what Fleming Initiative are doing specifically to do with antimicrobial resistance and thinking not just about how antibiotics are being prescribed, but actually in terms of behavioral science change is really interesting. Matt, I'm just going to shift focus slightly and sort of zoom in on the role of community health workers in addressing antimicrobial resistance. I'd love for you to just, first of all, tell us a little bit about your amazing background, how you started working with CHWs in Brazil, and just based on those experiences, what roles from your first-hand experience do you think that they could play in addressing this huge global challenge?
Well, I had the rather unusual honour and privilege of working with community health workers in northeast Brazil. I'm a UK-trained medical doctor, but shortly after medical school, I moved to Recife in the northeast of Brazil and requalified as a doctor in Brazil, and had the opportunity of working for about 4 years in a rural community outside of Recife in a place called Camaragibe, within what's called their family health strategy, which is their primary healthcare system. So I ran a single-handed GP practice with about 5,000 residents in that village. It's sort of a rural favela, essentially very impoverished context. But I was working with 4 community health workers as part of my team. And the way they were deployed in Brazil, and still are to this day, across the entire country is pretty unique and interesting, actually, and something we have a lot to learn from, because the community health workers there, they visit every household at least once a month in the small geographies, they call them micro areas, where they work. And each micro area has about 120 to 150 houses each. And they get visits every single month. So in doing so, and that's irrespective of whatever problems they're experiencing that month. And it's a really elegant model because it means the community health workers can pick up on problems really, really early on, sometimes before even the residents themselves know that they have a problem. They build that relationship, they get to know the residents extremely well. So through that experience, I actually noticed that, and I'm not the first to notice this, of course, or the last, but the community health workers are pivotal in an effective primary care system, because by virtue of the fact that they know their residents really well, they can identify, for example, critical things that are important to AMR issues. For example, who maybe has an infection, doesn't realize it. Access to primary care, getting appointments with the GP sooner rather than later, and improving that access so they can be put on appropriate antibiotics if necessary. Making sure that those community health that those residents are taking appropriately the antibiotics, finishing the course of antibiotics. It's really important that antibiotics, if prescribed, they are finished an entire course, because it's one of the important reasons why resistance eventually happens. So antimicrobial resistance isn't just a laboratory problem. It's not just a microbiological problem. It's not just a problem around incentives for creating new drugs, even as important as that is. It's also a behavioral issue around making sure that people who are prescribed antibiotics actually know the reasons why they've been prescribed them, take them appropriately, fully and completely, so that they avoid the possibility of resistance further down the line. So community health workers are really important in that regard, because they ensure that people who have been prescribed antibiotics are doing exactly what they need to do in order to avoid resistance, by that close engagement, day-to-day monitoring and management of that condition.
Now let's hear from community health worker colleagues in Brazil.
Como já foi falado também aqui,
Continuing with the topic, another issue is antibiotic misuse. Even when doctors clearly explain the correct use, people still take it incorrectly. Some people take only 3 or 4 days instead of the full course, or they save the leftover medication for later. And then there are people who don't have the money to buy the full treatment. If they can't get it for free, they buy only 1 box, thinking it will be enough. We try to educate people about this, especially the elderly. We emphasize the importance of taking antibiotics at the right times and finishing the full course. But the reality is, we can't monitor every single person who walks out of the clinic with an antibiotic prescription. Another role of the community health worker is that many people don't know how to read medication instructions. That's why we label their medicine boxes. We draw a sun for daytime doses and a moon for nighttime doses. But we can't catch everything. For example, I've seen mothers keeping leftover amoxicillin from a previous prescription, thinking, if my child gets sick again, I'll just give them the rest. This is why home visits by community health workers are crucial. Can we fix everything? No. But we can catch and prevent some of these issues.
And does this echo with your experiences, Dickson, as a community health worker, in terms of the support that you give to your community members that you're taking care of?
Yeah, I think the first thing I should mention is that, of course, I'll come with the question later, but the issues of AMR is to CHWs is not common. That's the first thing I should mention. I'm a CHW in my community, but if we go to the issues of AMR, it's a new thing to us. Most of the time is mentioned by the clinicians, the doctors, and yeah. But it's an important thing that we should be discussing at the community level. What I would maybe put a question to these two professionals is like, I don't know, how best can we take this issue of AMR to the community health workers so that they can be addressing this issue exclusively to the communities that they serve? Because to my understanding, one cannot take this issue if he or she is not very conversant with it. So I don't know, as the professionals, how best can we do this to the CHWs?
Well, I think it depends a little bit on the kind of CHW role in that particular country and context, because there's, many different ways of employing, recruiting, training CHWs in different countries. And I know that obviously, depending on the geography that community health worker is responsible for, to a greater or lesser extent, they'll be able to engage in this particular issue. I can tell you, though, that in Brazil, because the community health workers are employed, and that's a really important feature of their role, they're paid to work full time. They're paid to deal with any health or social care issue in the community level, not just AMR, but diabetes, breastfeeding, social care issues, loneliness, chronic disease management and control, and so on, screening uptake, immunizations, anything you can think of. AMR is one additional but very important aspect of their role. But they need to be trained, and they need to understand the importance of it. They need to understand, the prescription schedules and regimes that people have been put on if they have chest infection or anything else. A very good example, I think, of the way in which community health workers are being used, at least in Brazil, and I think also in other countries, is in directly observed treatment. And this is something specific to conditions like tuberculosis. And in Brazil, we had many cases of leprosy, now called Hansen's disease, which actually requires 6 months of antibiotic use, very complex schedule, daily pill taking, multiple pills. It's actually quite a difficult regime to adhere to. And it's so important to finish the course of treatment that actually people have to be directly observed taking the pill in order to ensure that they're actually completing the medication regime as required. If they don't, then very high likelihood of multi-drug resistant tuberculosis, multi-drug resistant leprosy as well, which will cause huge problems for public health. So the community health workers, because of their role going door to door every single day, are in a perfect position, much better than doctors are, who are stuck in clinics. They're in a perfect position to actually, each day, if somebody is on that drug regime, to actually go to that house and actually say, okay, let me observe you taking that pill, and they tick it off and they record that appropriately. Very few health systems actually have that ability to do that unless you have community health workers in place. So it's definitely worth the investment.
Yeah, it's an amazing example, actually, especially around direct observed therapy and multi-drug resistance. So like you were saying, Matt, if someone doesn't complete that 6-month course and actually stops at, say, month 3, you'll find that that antibiotic will then potentially no longer work and the person will develop resistance, and then you'll run out of options, essentially. I think from an equity perspective as well, it's really important, and that's where community health workers can play such an important role, because say someone is in a very rural area that's impoverished, community health workers are often going that last mile to reach those patients. And I think antimicrobial resistance is something that's going to affect everybody globally. So I think that is a hugely important role CHWs can play. I'm just also interested to ask a little bit about, in episode 2 of this series, we heard about the importance of co-design with community health workers and really involving community health workers in things like these training initiatives. Similarly, on a related vein, I think this is about the global health landscape not being sort of a top-down approach, and really trying to make sure that information and data is shared equitably both across different community health workers, but also partners. And so, Nina, I wanted to ask from specifically an AMR perspective, can you tell us a little bit about how you, the Fleming Initiative, are trying to avoid sort of siloed parachute programs where people might drop in, conduct research on AMR and then leave? I know you've been doing some interesting work with CamoNet.
Sure. So first of all, I think what Matt just rightly pointed out, AMR is not a medical issue. There's a huge paradigm shift around the how people recognize AMR. It's a societal issue now, and it involves huge kind of driving the behavior change around everyone. It's a societal engagement problem. It's not just medical doctors' responsibility. It's everyone's responsibility. But also why everything happening in the community is hugely important, because I always say that we are just a bag of bugs, like everyone carrying over a kilo of what we used to call gut flora. Now we use microbes in our guts, basically. So the bugs are always there, and some of them are already resistant. So essentially understanding the contextual factors, not just the use of medication, but also the household environment, for example, antimicrobial use in the local agriculture and aquaculture, all that drives AMR, and also the local epidemiology of infections in different countries. So that's why, community health workers can be hugely helpful. Now coming back to the co-design issue, I guess first of all, I think local community health workers are the one that with the local knowledge. First, so a typical example is, for example, we as someone working around data and surveillance system globally, we are looking at the numbers, which is the last stop. But first of all, we have to understand how these numbers were generated, how data was generated. And also, because numbers can be misleading, I have to say. Right. So we need the local knowledge. And that's why, engaging with who's working on the ground is critical. But also, in terms of more around using community health programs as an opportunity to gather data and using data better, that involves understanding of the local context as well. For example, if we see, data generated by health systems, we see prescriptions. But equally, there is a huge issue around, for example, drug shortage. So what has been dispensed on the ground, we can't see that unless we have the local knowledge. And also, for example, patients acquire antibiotics over the counter. That is something that monitoring that is a global challenge. No country has this kind of surveillance in place to understand what has been dispensed over the counter or what has been purchased over the counter, unless you have someone on the ground, reaching to each of the household and asking, what's going on. Similarly, understanding the household environment, understanding the behavioral, all that involves getting the local knowledge from a very early stage if you want to design any kind of intervention, especially those aiming at changing behavioral. And that's why I think co-design is typical. And now coming to what we have done as part of the Fleming Initiative and CamelNet. CamelNet is a Wellcome Trust-funded international research consortium involving 11 countries. So it's a very unique setting because each of the country hub, we call, have the full control of what they have done based on the context. So, for example, Brazil is actually one of the country hubs. So their work is focusing on, for example, wastewater, management of wastewater, surveillance and understanding, for example, antimicrobial resistant genes and also the antimicrobial concentration in local wastewater. Monitoring that and understanding how does that change the AMR burden in human. We also have the program there to understand, for example, infection burden involving family doctors, which is very different compared to the UK setting. So this is what we have been doing as part of the CamelNet, also Fleming Initiative as well.
That's fantastic. That's fantastic. Matt, I don't know if you've got anything to add, especially based on your own experiences in the past about how, we co-design some of these interventions well. And in episode 2, we've obviously heard extensively about this whole process from Karen Finnegan and Shibana Nagraj, but it would just be good as well to get your own perspectives around, how do we design programs well with community health workers, especially through the lens of AMR?
Well, I think it's quite simple. I don't think it's possible to design anything well unless it's with community health workers. To put it quite simply, community health workers are in this wonderful position where they are both part of the community and also the health system. So they can provide insights into what people care about, how people receive their information, how they will understand messaging, how best to tailor messages, not just in terms of linguistics, but in terms of the meaning and the concepts, because some of these are quite challenging things to really appreciate and understand. So really deeply understanding what the community, which is obviously as a catch-all term, but what residents, what members of the community really care about, how they understand the issues, what are the barriers and challenges, isn't something that we as clinicians can necessarily understand immediately. It's not inherent to our understanding. We need to have a way of accessing and gaining insight into those things. And so other than sort of anthropologically speaking, going in and studying communities, which never really gets us very far because it's it's about just observing, it takes forever to really understand. The best way to do it really is to actually work in partnership with community health workers and really understand what they understand, and put them in a position of centrality, let's say, in terms of designing interventions, education programs, messaging, health promotion, anything at all that's necessary to tackle the problem of AMR at the community level, because they're the people that know.
Exactly. And Dickson, what do we say at Chic? We say nothing about community health workers
without CHWs.
Yeah.
So we hope and believe that each and every planning activity has to be engaging CHWs. Otherwise, it's a good. There are a lot of initiatives that are being designed, but CHWs are not there. So this is time to involve CHWs so that we move together. Yeah. How can digital technologies be harnessed by CHWs to address AMR issues?
I'll try and answer that.
Yeah, it's a huge question. But
I mean, on the one hand, I think CHWs can probably help, as I said earlier, really help design maybe some of the digital interventions and solutions. Whether it's about monitoring drug use or point of care testing, for example, around antibiotic use and other things, and infection control in the home. They will be able to inform those sorts of initiatives at every step of that design process. And as we said earlier, it's really important that they form part of that to generate that end user insight. I think is really important. I'm aware of some digital solutions that actually identify counterfeit drugs and medicines bought over the counter, as Nina suggested. So there are mobile phone solutions, I think originating in Kenya and Uganda, used throughout sub-Saharan Africa, where you can scan the barcode of the medicine packet that you purchased to identify whether it's actually a counterfeit drug or not, which is going to have implications for its effectiveness, and therefore also particularly with antibiotic use in terms of AMR in due course. So I think that's an important solution as well. But point of care testing and solutions that monitor adherence to medicines, perhaps pill counting. I'm sure there are digital solutions out there. Community health workers are going to be pivotal to all of that.
That's fantastic. And Nina, in episode 3 and 4, we spoke about the potential role of AI. In relation to antimicrobial resistance, what could be out there and how could AI help combat AMR? And could there be any uses for that technology that CHWs themselves could particularly use that you might envision?
Sure. So AI definitely can do a lot in terms of addressing AMR, from personalized medicine, for example. Antimicrobial dosage is part of the precision medicine research we are currently doing as part of the CHWD and Fleming Initiative. Essentially, we're saying there's no single dosage that's suitable for all different type of patient. So to personalize that involves fully understanding of the patient characteristic. For example, what are the chronic conditions the patient currently having? Polypharmacy, that means patient taking multiple drugs, and that might interact with antibiotic treatment, but also understanding the environmental factors around the patient, and also pre-exposure to different type of antibiotics. That all changes the how we change the antibiotic regimen in terms of treating patient. But also that involves real-time monitoring of drug concentration when antibiotic being admitted. So AI kind of like provide a solution in terms of predicting a kind of outcomes of antibiotic treatment before and once it's being administered, and also predicting, for example, risk of some adverse events like chronic kidney injury. That's a project we're currently doing for patients receiving antibiotics, or predicting outcomes for those patients with multiple chronic conditions, stratify them better to different patient pathway based on the individual risks. AI also can be linked to with developing of point of care diagnostic, for example, using machine learning to understand the different type of, like, for example, signals generated by different technology that's sensing antibiotic concentration in blood, for example, also monitoring pre-exposure to different antibiotics. So that's all examples of what AI can do. But also AI can be used to develop for example, infection diagnostics, like, for example, reading radiographic figures or imaging of patients. So all those are examples. However, I want to say that globally, the current challenge we're facing in developing AI or machine learning tools is we are using highly skilled data set to train and developing AI tools. We know that as a fact. I'm not shy away to say that, because the data we use to train and develop AI tools, they are skilled in a way that they are collected from already more developed or resourceful settings, because fundamentally, they are the sectors where they can afford to generate this kind of data. So essentially, we're seeing skilled data set that's skewed to white male, for example, in both ways. First of all, we must have the kind of like the IT or technology maturity to make sure the data can be generated. But also, we are collecting this data from the patient who having some sort of health literacy. So they are involved in medical research. So they must be literate or health literate in a way. And that's how we know that the data we use is skewed in different ways: ethnicity, comorbidity, et cetera, et cetera. So community health worker can contribute hugely by making the data more equitable, by collecting data from harder to reach population, vulnerable population, the population with low both literacy and health literacy, for example. So that's the first thing I want to mention here.
Yeah, that's fantastic use, Matt. Yeah, please come in on this.
Yeah, I'd maybe complement that actually as well. I agree entirely that AI models are only really as good as the data that you feed them with, and community health workers therefore play a really important role in making that data more equitably sort of derived, so to speak. But I often sort of think that it's as important to have not just artificial intelligence, but also emotional intelligence, and having a community health worker that really deeply understands their residents, to be able to influence their behaviors, and actually even when we talk about digital clinical decision-making tools that can help community health workers actually identify whether something is or isn't likely to be an infection. So for many, many decades, we've already had sort of decision-making protocols, for example, that community health workers can use to identify whether a child has a pneumonia, for example, or whether it's just an asthma attack or similar, or dysentery as opposed to just a regular gastroenteritis of some other sort that isn't infective, perhaps. There are actually protocols already in place for community health workers to actually help clinicians and the health system identify when an infection actually might be likely. So coupled with also the community health workers' ability to shape the care-seeking behaviour of residents. People who may be sort of at the slightest sniffle go and get antibiotics over the counter, re-educating them around the appropriateness of that or the inappropriateness of that kind of behaviour is going to be really important. And then a final point I wanted to make around data and the role of community health workers that we often don't think about isn't just counting the cases, but also understanding our denominator. So our population, what population are we actually applying all of those cases to? And actually, even in the UK, we really don't know what our how many people we have that live in this country. We just don't know. It's all based on census data, which is usually could be anything like 10 years out of date. So one of the benefits, again, going back to the Brazilian model, is because community health workers are universally deployed across the entire country. There's 275,000 community health workers covering 75% of the population. They're able to generate essentially census quality information about their population every single month, update it every single month. So they have what we call a denominator. So if we have, 10 cases, you can immediately say that's 10 cases out of a proportion of the population that exists, which means you can then do epidemiological characterization of the problem in a far more sophisticated way than we currently can do here, which is a little bit based on guesswork.
Yeah, and I think that's an amazing point. It actually ties really well into episode 4, where we spoke about the importance of data quality. And I think the role community health workers can play in helping to obtain an accurate denominator in terms of the size of the population, and is so important. And it ties really well into the issue of AMR, because I think we need quality data in order to make good decisions. And like you said, Nina, especially with AI, the quality of the AI tool is only as good as the model that's been created, and that relies on the good data. So this is really interesting. Matt, I just wanted to touch on something briefly. I think a lot of these conversations we've been having have been around or framed around community health worker models in what you might term low and middle income countries. It'd just be really interesting to hear a little bit about your work with community health workers here in the UK. And again, if we could frame this through the role that they could potentially play in antimicrobial resistance or combating antimicrobial resistance, that'd be really interesting.
Yeah, thanks. So I came back from Brazil in 2004, and so it's been quite a long journey advocating for the translation of the community health worker role into the UK context. And things really only began in earnest during COVID, where I think we began to realise that our public health system is really not quite as efficient or effective as we would like it to be, and primary care was really struggling, and many sort of hard to reach groups, what we also might call easy to ignore groups, really disadvantaged throughout the pandemic and for many other reasons. And so I think there's a burning platform to actually really think differently with respect to our public health system in the UK. And that's when we were able to pilot the community health worker role in Westminster through the effort of colleagues like Dr. Connie Jungens and Sol Kaufman and Sheilin Yogi and many, many others within Westminster to pilot community health worker role, how they deploy it in Brazil. for many years, we battled against sort of a narrative that community health workers are really a poor solution for poor people, which is utterly incorrect. And it's a real prejudice, I think, that we had to battle against culturally and cognitively to get this over the line. But we've managed, and actually we now have community health workers based on the Brazilian deployment strategy in 27 different localities around the UK, particularly large in Cornwall, where they have nearly 60 community health workers, in Westminster 29, and many other locations. It sounds like small numbers, particularly compared to Brazil, but you've got to start somewhere, and it's definitely scaling, and we're already seeing effectiveness and impact for residents in all the locations where the community health workers are. And it's really unsurprising. You know, they improve immunisation uptake, they improve screening uptake, they improve NHS health check uptake, they reduce admissions, we're already seeing in the data, to hospital, they reduce attendances at A&E really rather significantly, in exactly the same way that they did in Brazil. You know, we sometimes think, don't we, that, you know, high income countries are just sort of somehow just very different to low income countries, but actually where the rubber hits the road, what really matters is, do you understand your community? Can you support them appropriately to get early support at the right time, just when they need it, for all sorts of different things. And there's absolutely no empirical reason why community health workers can't work in that way just as well in the UK and any other high income country as well. So I agree entirely. You know, this sort of the logic that it's a solution for systems where they can't afford doctors is just utterly inaccurate, and it ought to be the bedrock for any effective primary care system in any country.
Thanks for the overview of the work. Really excited to see the model hopefully expand. And I really like how you framed that. I do think there's incredible benefits that community health workers can bring to so many people. And really excited to follow the progress of this. Nina, I might just ask for you, what are you most excited about that Fleming Initiative are working on at the moment? Have you got any interesting projects or things that we should be keeping an eye out for?
There's a lot happening at the moment with Fleming on the horizon. So I can give you a few from what I have been involved. So I'm specialized in data linkage. So that's a very special side of working around data. So I'm the one that providing ingredients for all my colleagues to develop amazing AI models, for example, understanding the epidemiological trends, etc. So I'm basically providing the ingredient by linking data from different sectors and different kind of like data generators, I would say. So from laboratory data that tells you the story about the bugs, their genes as well, the genomic data, and that linking them with both clinical data from the patient themselves, but also the non-clinical data from the environment, their household, the behavioral, and also the data that is not traditionally used from medical reason. For example, administration data that gives you a good denominator, for example, but also other aspects like globally, say, the distance to the closest clinical unit that provides operation, for example, other kind of health systems data in terms of financing, the density of health workers, for example. So I'm bringing all them together. So that's what we call the data linkage and integration. So essentially, my work at Fleming, also Chemunet, is trying to demonstrate that, first of all, we are avoiding burden the already overburdened healthcare system globally by saying you must implement something that is just for AMR, because that's a very unethical way and also unrealistic as well to ask. What we're trying to do is demonstrate with the already data infrastructure that in place, by linking them together and using them more intelligently, we can tell much more about, for example, the overall burden of AMR and also what should be designed and implemented. And also we are collecting data around, for example, public messaging as well. That's a huge thing we're trying to do, raising both awareness and changing behavioral in the public. For example, I'm from mainland China. So there's a very typical story I always tell about AMR is, it's a small thing, but in our language, anti-inflammatory and anti-infective are used interchangeably. And that's why for years, people are using antibiotics as a medication to treat inflammation. Which drives huge issues around inappropriate overuse and also AMR in downstream. So there's huge work has been done trying to put the right message in place. So this is a thing we've been doing. But how are we monitoring that? How are we monitoring kind of like the effectiveness of those public campaign? How are we demonstrate the cost effectiveness of this kind of intervention? So that's why we're trying to demonstrate data must be used intelligently, but weighing the data around the bugs from the laboratory or from the hospitals alone are definitely not enough. So my work is about bringing them together. That's why around data linkage and integration. So yeah, it's an example of the work we are currently doing.
Yeah, it's fantastic. And I really like the sort of whole house approach that you're taking and really trying to make sure that, you're translating that really important information that you're obtaining in the lab through to what can be used actually at the bedside, and also in the households and communities with community health workers. I don't envy you. It's a huge task and extremely complex, but really worthwhile and super important work. So thanks for all that you're doing and the team at the Fleming Initiative to do this. Dickson, I'd like to hand it over to you just to see if you've got any reflecting thoughts that you'd like to ask Matt and Nina.
Yes, maybe the question would be, as Nina mentioned about some of the challenges being faced in harnessing the issues of AI. So to me, I'll go straight to the issues of community health work programs. What are some of the challenges that so potential that would we need to consider when we are about to harness issues of AI in the communities?
I guess first of all, money is always the number one issue, I have to say. But what is money? Where are we needing money for community health worker? I guess the first of all is the funds or the resource we use to expand this capacity, so that providing the adequate training for the community health worker being able to take upon the tasks around, for example, generating data around infection and AMR. That's a challenge we're currently facing, but also understanding what the best practice in terms of collecting and using data in both ethical, secure, and equitable way. So that's a challenge. In terms of the data around AMR, I guess what we're currently missing hugely globally is not the burden of AMR. It's the prescribing data. That's a missing piece in the whole picture. We are really lacking data around antimicrobials usage, especially in the community and also in the environment as well. But meanwhile, we know that the antimicrobial use in the non-human sector drives the AMR in human. So how we can train the community health workers to take up on the task of capturing data in that aspect, that for me is very critical. But also, meanwhile, we know that community health workers or community health programs are already stretched very thinly in a lot of countries, especially in the resource-limited settings. So essentially, how we can basically design a good program for task sharing. So for example, there are community health workers involved in immunization, HIV programs, malaria program, even tobacco use, for example. How are we going to utilize the existing community health programs by integrating the work around AMR into these existing programs? For me, I think it's a kind of like, this is a way forward, at least in my opinion.
Yes, it's really helpful. I want to thank both of you. I feel like we've gone through a whistle-stop tour, but a very comprehensive tour as to what antimicrobial resistance is. It's obviously a huge global problem, and thank you, Nina, for outlining that and flagging it as such a major issue. Also, Matt, thank you for touching on the important role that community health workers play, not only from your past experiences in Brazil, but your current experiences here in the UK. The importance of co-design, data quality, how digital could fit into combating AMR. I just wanted to ask both of you, perhaps starting with you, Matt, what would be one, if you can pick one out, take-home message from this discussion that we've had that you think is important that you'd like to reflect on?
Thank you, firstly, so much for the invite. It's been a really interesting and rewarding conversation. I've enjoyed it immensely and learned a lot as well about AMR and the work of the Fleming Initiative. But I think for me, the take-home message is that AMR, obviously, a hugely important issue of public health concern in any country. This issue is going to transcend boundaries and borders. We all need to be aware of it. But that community health workers need to play an absolutely central role in its identification and the solution to it. For me, the risk, however, is that we view this as a singular vertical problem, let's say, and we develop programs specifically just for AMR in the community. And that's where, and echoing what Nina said, I think it's really important to integrate this issue into existing community health worker programs. Community health workers are an infrastructure through which you can deliver and address any issue such as AMR, but also diabetes, breastfeeding, nutrition status in children, which, by the way, will be a very important issue to avoid and infection risk and so on. The community health workers, therefore, are just an infrastructure, and AMR shouldn't be viewed as a singular problem area that can only be solved through yet another initiative vertically deployed or parachuted into a community. Let's work within a community health and wellbeing worker, community health worker system in order to get this problem solved.
That's great. Thanks, Matt. And Nina, what about yourself?
So I'm just going to say something with my data hat on. So I want to say that data can be misleading. So having the local knowledge is critical. The first thing you want to know is what is the flaw in your data set. That's the number one thing you should do. Acknowledge that there's always a caveat. There's always a limitation about how much data can tell you. So yes, I'm happy with my massive data set. I'm happy with my AI tools, but unless you understand what is currently missing, otherwise. The decision is not robust enough. So I guess that's what I'm reminding myself about everyone walking around data in AMR and epidemiology per se. So
fantastic. Thank you both so much for joining us. It's been an amazing discussion, really fascinating topic, and just huge thanks to both of you for your time.
Thank you.
Thank you.
We hope you enjoyed this episode. If you did, please consider sharing it with a friend or a colleague and leave us a review wherever you get your podcasts. This also concludes this podcast series. For more information on the work we do, please visit joinchic.org, where you can sign up to our monthly newsletter and research roundup.